Before I begin, just have a look at this. This is an eye. Okay. I operated this kid few months back. This is endophthalmologist, right? The greenish hue you see is fluorescent dye, which we put to examine the cornea. So this child was given steroid eye drops by Ridgeway for red dye. So this is just a reminder. So you can see pus inside the eye, right? So all eye cornea and whitish area is pus. It's all pus. So we could not resuscitate. So we could not give any sort of useful vision to this side. Prescribing steroids to each and every case of red eye is a bad practice. So, what are the common eye problems in children? In our clinics, what we see, mostly children come to check their vision, children with refractive errors, children when we diagnose amblyopia, amblyopia is reduced vision following any cause of reduced vision. Then children with squints, sometimes parents bring their child just to check whether the child has a squint. Allergic eye disease, children come with red eye, some have allergic eye disease, some have viral conjunctivitis, and some have tearing from birth. That is tearing from birth. So that is a congenital nasal contact obstruction. Trauma is also common in our case. But there are other things that you would not see in your practice, but which are more important as far as the vision is concerned, as far as the life is concerned. Inside retinoblastoma, congenital cataract, congenital glaucoma, those are our bulk of our workload, but those things we do not see because they are not common. So when children come to you, so how often do you ask about their ocular health? How often do you ask about the history of their visual milestones? Sometimes you might forget, but it's very important because none of the children, they come with, they can complain about their visual symptoms. So their level of, their ability to complain regarding their visual symptoms is very low. So they don't say, I can't see, I can't, even older children, they just come with, you can use. You are supposed to ask a few things in the family history, particularly if there are vision threatening problems in their family, early childhood eye problems in the family, particularly steroid use, and a few questions on visual milestones. All you need to have a pen torch, a good quality pen torch, but your skills in direct ophthalmoscope. Checking with the direct ophthalmoscope is very important. Most of the doctors, they are scared to use the direct ophthalmoscope because as medical students, we hardly get the opportunity to use this. Because we don't know about that instrument, we hardly use it. So, but it's very important. So, to check the red reflex, you need to know how to use the ophthalmoscope. You don't need to check the fundus in each and every patient, but you need to check the red reflex. So take this case as an example. So this is the 6 months old baby bought. So child has presented to the pediatrician with fever. So pediatrician has noted the mother's eyes were removed when she was a baby. So when the pediatrician asked the history, mother doesn't know about anything about the history. So pediatrician then referred the child. Pediatrician has not seen any ocular problem in the child, but asked the family to go to an eye surgeon. So eye surgeon has noted the child is having multiple tumors in the eye. So this is a bilateral retinoblastoma. So in truth, the mother had bilateral advanced retinoblastoma during infancy, and Because at that time there was no successful treatment, mother's eyes were removed as an infant. She doesn't know that. And now she brings her children to our clinic. But their eyes were saved with modern treatment. So, yeah. Sorry, this presentation keeps on skipping. Can I take this laptop here? Sorry, it's a bit unusual day for me. When I was walking to the clinic, there were very much less number of patients. So I thought it's an easy day for me. And then I went to the canteen. I met Vasan. Vasan said, "Sir, we'll start at 11:30 strictly." Then only I remembered I have a lecture. So then we somehow found this lecture, and but I know how to do this lecture, so don't get
We can only direct channel.
So you need a few things. As I said earlier, with the pen torch, you can see few things. Mainly obvious ocular problems like, now what is this? And what is the importance of noticing these things? This is a limbal dermal, right? So these subtle congenital abnormalities can be associated with systemic syndromes. So not only then that they can cause ocular problems, so this can cause significant ocular problems by causing distortion of the cornea. So distortion of the cornea, reduced visual acuity, lifelong vision-related problems. But the child may have things like systemic syndrome. So this child may have golden house syndrome, which can have renal manifestations as well. So it's important to notice these sort of subtle ocular problems. So what is this? It is the iris coloboma, right? So anybody can see this with the pen torch. You don't need a street lamp. So it can be associated with systemic syndromes as well. And in children with the pen torch, you can check the alignment of the eyes. It's very easy. But you never shine the torch to the patient's eyes directly because they will squeeze their eyes, right? It's natural response. You rather direct the torch to the patient's forehead or the chin area and pretend you are playing with the pen torch. And you observe, but you don't play with the child, you observe the light reflex of the cornea. This is not red reflex, this is just the light reflex of the cornea, right? You can see it's in the center of the cornea, right? So there is no manifest squint. There's no obvious squint in this patient because the reflection from the torch light falls right on the center of the cornea. But if it does not fall on the center of the cornea, then it is a squint. Now, what is this? Now here, in this side, it's on the center of the cornea. In this side, it's off center, right? So this is called exotropia. It's a divergent squint, which needs proper ophthalmology referral. You don't need to refer to a pediatric ophthalmologist. You can refer to any ophthalmologist that you have access to. Next instrument is the direct ophthalmoscope. With the direct ophthalmoscope, we call it direct ophthalmoscope because we have an indirect ophthalmoscope as well. But you have only one ophthalmoscope, that is this, the handheld one, that is a direct ophthalmoscope, right? But you don't need to get confused with the different types of ophthalmoscopes, but I'll just describe the direct ophthalmoscope, just the normal handheld ophthalmoscope in your wards. So there are two things you can observe with the ophthalmoscope. One is the red reflex, one is the fundoscopy. So red reflex is a very, very important test that you should practice because you are supposed to elicit the red reflex in newborns. To see the red reflex in a newborn, you should be thorough with the red reflex examination in other, like anything else. Now, say for instance, murmurs. So to examine, to know whether there is a murmur or not in a newborn, you should have examined many other kids or adults beforehand. So this is also something like that. So using ophthalmoscope to examine red reflex in older kids or all older people is important to develop the skill. Then only you develop the ability to examine the red reflex in a newborn, because which is a mandatory examination in the newborn examination. So this is actually from a textbook I took. This is normal Caucasian, but normal white person's red reflex. Right? It's little bit orangey. This is the red reflex in our people. Our children are not this bright. Slightly darker than this because of our pigmentation in the eye. So the red reflex is normal in both eyes in this person. Here, the red reflex is present in this side. Here, the red reflex is absent. Okay, so that is a significant pathology which needs urgent ophthalmology referral. Here, in this side, the red reflex is present, and in this side, what you can see is the yellow reflex, right? Or you call it xanthochoria. That is usually due to a tumor or a condition called Coats disease. So anyway, that patient also needs urgent referral. So here you can see clear red reflex in this eye, but the red reflex is little bit darkened on the fellow eye, right there. The red reflex is slightly darker. So that is due to the squint, the misalignment of the eyes. So misalignment also can cause muffling of the red reflex. So here you can see both eyes, the red reflex is little darker. That is due to high refractive. The patient was having high myopia. So you can't see the red reflex in the normal way. You have to examine the fundus. So this is the ophthalmoscope. First, you should release this lead latch if there is one. And then these dials you have to be familiar, right? So for red reflex examination, you should select the larger aperture. So different ophthalmoscopes, different makes have different dials, but almost they have the same principle. So for red reflex, you should select the larger aperture. And the number here should be 0. You can, you can take it to 0 by dialing these the cogwheels on either side of the ophthalmoscope. Sorry, I'm going to deep, very basics because it's a mixed crowd. And there is another dial saying plus and minus. So you have to keep the lever between plus and minus. Sometimes it's a minus 20 and plus 20. So you have to keep it in between. So what is red reflex? So your ophthalmoscope has only a light source, a slanted mirror. That's all, right? Ophthalmoscope is not a complicated instrument. We have much more complicated instruments in our clinic, but this is a very simple one. So the light source emits light. The slanted mirror reflects it into the patient's eye, and it goes through the ocular media, cornea, anterior chamber, lens, vitreous. Finally, it's the retina. Okay, then the light reflects back from the retina, goes through the same ocular media, and goes through the hole in your ophthalmoscope and focus on your eye, right? So that is the red reflex. So you need a distance between you and the patient to get this, right? So the technique is described here. You should stay about half a meter from the patient. It's not like checking the fundus, right? So you select the larger aperture and aim both eyes simultaneously. So if you can't see the red reflex, you can darken the room. It will dilate the pupil. And you should ask the patient to look far. Never ask the child to look at the light. It will elicit the light reflex only, and the accommodation as well. So it will further constrict the pupil. You should ask the patient to look over your shoulder somewhere. You can ask the parent to walk back and distract the child to a distance place. In desperate situations, you can dilate the pupil with propicamide, but in general practice, I would not advise you to dilate the pupil. But what we do is we anyway dilate the pupil to examine the fundus. Right? So here, how you see the red reflex. This room is little, a lot lighter. You should not have light to this extent. Should darken the room. And ask the, not this room, the room where you are examining. Anyway, so yeah, so this bit we have explained earlier. What is normal red reflex and what is yeah. So the most common abnormality in the red reflex you would see. I mean, most of the patients you will see normal red reflex, right? So you will give up examine red reflex one day saying I can't find any abnormality, but one day you will find a leukocoria, a white pupil, which signifies cataract. In children, it's very, very important. In adults, of course, you can see if you keep on seeing the red reflex, but in children, it's very, very important because there is a window period that we have to do the cataract surgery and clear the visual axis for the child to gain lifelong vision. So it's very important to refer a child with cataract early than later. So fundus is the window to the brain, isn't it? So if you can examine the fundus, you will know a lot about the status of the brain as well. So when you first attempt to see the fundus, you will see something like this. You will never see that nice textbook picture with disc and the blood vessels and the macula and everything. It's a digital picture. You will not see that through with your eye, through the pupil. So you will see something like this. What you should aim is so you will not see this, right? When you look at with the this thing. So you should aim at a V, at an arrow like this, right? And follow that arrow. Follow this arrow, right? Further. So then you will find another arrow. That is a bifurcation of a retinal vessel, right? So you go further, then you will find the disc, right? So you examine the disc first, then retinal vessels, then the macula. You keep the macula to the last because that is the most sensitive part of the retina. If you examine the macula first, the patient will get offended. So disc, you notice the color, right? It's very important because the disc is this color can indicate optic atrophy. Right? Optic atrophy can be a feature of cerebral pathology, increased intracranial pressure or tumor, something like that. So there is a thing called Kestenbaum sign, which is not very apparent with the ophthalmoscope itself, but it's very it can be elicited with the slit lamp actually. That is a tiny blood vessels crossing the margin of the disc. They are absent in optic atrophy, but you can't see with the ophthalmoscope. Anyway, this is papilledema. You can't say it is papilledema because what you see is disc edema, right? Papilledema is bilateral disc edema due to increased intracranial pressure. But this could be disc edema, this could be optic neuritis, this could be papilledema, this could be a tumor, this could be any leukemic deposits on the disc. So there are a lot of differential diagnoses to this. Anyway, papilledema, the disc edema we discussed. So the cup also important because cup to disc ratio is the important thing, which is the important feature in diagnosing glaucoma. So I will skip this few slides because that is for the medical students. So in your practice, if you get a child with sudden onset tearing, child can't open the eye. Now see, think about that clinical scenario. Child can't open the eye. Now it's 10 p.m. You're about to close your private practice and go. But you can't send the patient back because it's an emergency, isn't it? Child is in pain, tearing, parents are excited. So what would you do? Shiran will definitely call me, but I will not answer the phone at that time. So you what you can do is a sensible thing is try to pacify the parents. And what is handy to keep in your practice is uh, something local anesthetic. Right? There are dedicated local anesthetic eye drops like proparacaine, but you don't need to buy those things. Those are expensive, and there is a shelf life. You can keep in your fridge. You can keep lignocaine. It will be useful anyway. So you can put plain lignocaine eye drop, plain lignocaine drop. If it is sterile, that will that's okay for the ocular surface. That will anesthetize the ocular surface after. It will not anesthetize soon, so you have to wait a couple of minutes. It will take some time, but you have to know how to invert the lid to see the subtarsal or the foreign body under the lid. So it will anesthetize the ocular surface. Then if there's a corneal foreign body, you can see it. If you don't see a corneal foreign body, you can invert the lid slowly and see the subtarsal foreign body. This you can remove in your normal practice. You don't need a slit lamp. Right? Something like this, you can remove. That area is already anesthetized. You can take a cotton bud, put few more local anesthetic eye drops into the cotton bud, and just brush it off. There will be you warn the parents that there will be a drop of blood or two. Otherwise, they will get excited. Dr. Memakara and Leta. So this tiny foreign body, which is embedded, you might not be able to remove in your practice, or try not to do it. So you leave it for an ophthalmologist. But anything superficial, you can remove. So the next topic is red eye. I think that is what you are waiting for, right? Management of red eye or pink eye. So what would you do for red eye? I am 100% against. Today morning I was telling my MOs also. I am 100% against prescribing antibiotics for each and every red eye. I am 100% against prescribing steroid eye drops for each and every red eye. Steroid example I showed you in the beginning. What can happen if you prescribe steroids to the wrong person? Right? I mean, most of the red eye cases are conjunctivitis. The treatment of conjunctivitis is steroids, right? Because conjunctivitis is viral. But not all the red eyes are conjunctivitis. Right? So if you prescribe steroid to a corneal ulcer, it will lead to a case of endophthalmitis, right? So so you have to take a brief history to make up your mind to whether to refer, whether to treat, whether you need an urgent referral, right? So itching is important in cases of red eye. So itching is important because itching is the key feature of allergy. So what you can do is safely you can prescribe oral antihistamines and topical. There are topical antihistamines like olopatadines, right? Things like that, ketotifen, or there are topical drops. You can prescribe them. I'm not going to mention the trade names, but you can prescribe. So irritation is a key feature of conjunctivitis. and keratitis, things like that, which needs referral to an ophthalmologist. So loss of vision, reduction of vision, blurring, things like that. Children are very vague. So for anything they will say, I can't see, right? Blurring, double vision. So those things are confused in children's mind. So any issue with the vision, you can ask a couple of questions to verify whether it is real reduction of vision or not. But I think most of the vision related problems you have to refer. If it is associated with pain, if the red eye is associated with pain, that is most likely keratitis, the mildest case. Or in the worst case, it could be a corneal ulcer or a corneal foreign body. So those symptoms are important. So photophobia is another symptom, which could be a feature of keratitis. So keratitis is a result of conjunctivitis. If you don't manage conjunctivitis properly, the child will end up in keratitis. So the child will develop blurring, reduced vision, and pain at the end. So fever and red eye, basically you all are the experts for that, not me. So if the child is having fever with red eye, what I do is I refer to a pediatrician. Right? So if there is a discharge, you have to verify whether it's a watery discharge, mucoid discharge, or mucopurulent discharge. But usually conjunctivitis starts with watery discharge. You might think it's a purulent discharge always, but it's not. It's a conjunctivitis starts with pink watery eye. Right? Few days after only the discharge comes up. So if there are things like lump, cellulitis, periocular swelling. So fluorescein is a very important dye which we use in our clinics to look at the cornea. I don't have a picture here, but I will show you at some point about fluorescein staining. So a newborn with red eye, which is a common thing, isn't it? So ophthalmia neonatorum is a very specific infection. The conjunctivitis of newborns, that is conjunctivitis in a baby less than 28 days, is an emergency. Right? So that is usually associated with periocular cellulitis, very purulent discharge, usually socioeconomically poor parents, and normal delivery. But ophthalmia and neonatorum can be community acquired as well, because it can develop after child goes home. Technically, it is ophthalmia neonatorum because it occurs in a baby less than 28 days. So that also we have to manage properly. In this instance, steroids and antibiotics both indicated. If it is a normal delivery, then you have to investigate the mother and her partner, give the child appropriate antibiotics, intramuscular antibiotics, do the eye swabs, and necessary investigations. So this is an emergency. But remember, not all eye discharges in newborns are not infections, not ophthalmia neonatorum, right? And for all the children with red eye, please do not prescribe fourth generation fluoroquinolones, which is the last resort of topical antibiotics that we have, right, for severe ocular infections. So please get rid of the habit of prescribing high-fi ocular antibiotics for children and babies. So viral conjunctivitis, as I said earlier, it starts with non-purulent discharge. So here, it's easy to diagnose. what you do is you just invert the lower lid and see, right? Unless you see lots and lots of children like that, you will not know which is normal and which is not normal. Because anyway, if you do like that, the surface, undersurface of the lid will be slightly reddish. You will not know whether it is normal or not unless you see lots and lots of normal patients, right? So in normal babies also, you can just do like that and see, right? So in conjunctivitis babies, when you do like that, they have, when you shine your torch into the fornix, you will see the follicular reaction. I don't have a picture here, but yeah, follicles, I don't have a picture. I have papillae. But under surface is not regular. You will see bumpy appearance of the surface of the conjunctiva. So here, what you can do in your practice is you give them, hygiene advice and all those, and not to send the child to school for at least 3 days, and hand washing, things like that. So what are you going to prescribe? Are you going to prescribe anything or not? You can prescribe, that's fine. You can prescribe antihistamines because child is symptomatic with itching, child may be having irritation. So you can comfort the child with some antihistamines. Also, you can give a topical antibiotic, but not a 4th generation high-5 fluoroquinolone antibiotic. Right? And other thing you have to avoid is common ENT and eye drops. So just look at the label. If the label says ENT and eye, don't prescribe. Eye is a much cleaner organ in your body, not like your ear. Right? So I'm just joking. If any ENT doctor here, please forgive me. So because ENT drops have different vehicles, different preservatives, which are not suitable for the eye, which may not be suitable for the eye. So ocular drops have different vehicles, different vehicles, different preservatives, which are appropriate for the ocular surface. But ENT drops are not like that. They have catered for the whatever in the ear, not for the ocular surface. So avoid prescribing common ENT and eye drops to the eye. So cold compress will help to relieve the symptoms. But if the symptoms do not resolve within 3 days, you can advise the patient to go to an ophthalmologist just to see whether steroid treatment is indicated. But if the patient comes to me on day 1, I prescribe steroids. I don't ask them to come in 3 days to get the steroid treatment. I give steroid treatment on day 1 because I can examine the cornea very well. But you are not at that position to examine the cornea. So you can ask the patient to wait 3 days. If the symptoms are not resolving, then go to the ophthalmologist. So to give steroids, whether combined with the antibiotics or not, you have to examine the cornea properly. You have to examine the anterior chamber properly. To do that, you need the slit lamp. Right? Unless you have examined the patient properly with the slit lamp, you can't give topical ocular steroids. You have to examine corneal problems. You have to examine uveitis. And these topical steroids have potential complications as well, like glaucoma and cataract. So this is the allergic eye disease. I told you itching is the key symptom. So when you examine the cornea, you can see these with the pen torch. These are called contrast dots. These are accumulation of allergy mediating cells around the limbus. Right? So that signifies severe allergic conjunctivitis. So this patient has to be treated by an ophthalmologist and needs steroids and tacrolimus and all that. So this is a sort of a corneal ulcer, but it's sterile. It's called shield ulcer because it's a reaction to the allergic reaction in the ocular surface, and it's a reaction to rubbing as well, because these children keep on rubbing, so ocular surface gets different. So, where is it? So this is the other papillary reaction you see. Most commonly, the subtarsal papillary reaction in allergy. Right? So when you invert the lid, you will see the reaction. So these are limbal papillary reaction. And this scenario, the first picture you might see in your practice more often than not. So sudden noticing of red eye, a red patch in the eye. So if this occurs in a newborn, particularly after normal delivery, which is normal, it's a birth-related subconjunctival hemorrhage. But if it is too large, it's better to refer to an ophthalmologist just to exclude things like vitreous hemorrhages, retinal hemorrhages, things like that. In an adult or older child, better to get a blood pressure reading. If there's cough, you can treat. Some drugs which can cause, it can interfere with the clotting mechanism, can cause this with even minor trauma. Platelet abnormalities, vitamin C deficiency, certain diseases can cause. So what is the bottom picture? That is also a subconjunctival hemorrhage, but it is a severe spectrum, right? which we call chemosis. Severe subconjunctival hemorrhage, which could be a feature of trauma, or sometimes even things sinister as carotid cavernous fistula, thyroid eye disease, things like that. So in children, all the children with this subconjunctival hemorrhage, we dilate and have a look at the fundus, because because the child does not bring out the history. It could be a accidental injury, it could be a non-accidental injury. So just to exclude any possibility of any trauma. So here, this child is having, he doesn't have a red eye actually. You can see the eye is white, isn't it? But white eye, but the eye, the skin is red. So that is preseptal cellulitis. Right? In a young infant, it's important because it can spread. The infection can spread into the orbit, because their orbital septum has not developed yet. So children less than 2 years, preseptal cellulitis would be the first sign of orbital cellulitis. So that child needs referral to an ophthalmologist. So in children less than 2 years, we always give IV antibiotics. It could be a feature of sinusitis, so we refer to the ENT surgeon. But make sure there's no local cause like a chalazion. I mean, if it is a simple thing like chalazion causing preseptal cellulitis, no need of ENT referral. But of course, we have to exclude trauma and all that. But this is the extreme. Child came with preseptal cellulitis. Few days later, child develops orbital cellulitis. So you can see the abscess inside the orbit. Actually, it's not in the orbit; it's in the sinus, right? So the lamina papyracea is protruding into the orbit. Right? This is the lenticular abscess. So abscess is in the nose, the nasal cavities, not directly in the orbit, but if this ruptures, it will go into the orbit. So this is a ill-looking child, needs IV antibiotics, ICU care, and all that. It's an emergency. I'm sure you will not try to manage. So lacrimal system is important because you will see lots and lots of kids coming with tearing. Watery eye with or without discharge in an infant like this So again, you can see the eye is white. Okay, there is a discharge. It's not purulent. How do you know whether it is purulent or not? How do you know? I just say it's non-purulent just by the look at it, but you can do cytology and all that to exclude pus cells. But I mean, practically you don't need to do that. Basically, if the eye is white, it can't be purulent. So this is just the normal eye discharge in little bit more augmented uh, amount. So here, if the eye is white, again you can do that and see whether there's any reaction going on inside the fornix. If it is white, I mean, if it is normal pinkish color, don't prescribe anything. So congenital nasolacrimal duct obstruction does not need any antibiotics because antibiotics is not going to solve the problem. Because the root cause is the valve of Hasner, which is on the edge of the nasolacrimal duct, is closed. It's not open in these infants. The day it opens, the tears will start flowing into the nose like any other person. And until that day, the tears will just overflow. The discharge will just overflow from the eye. So no antibiotics. What you can, so what do you do? I mean, if you don't do anything, the parents will go to the other doctor. So you will lose your practice. So you have to do something, right? You can teach them about massaging. So I have seen different people advising different types of massaging techniques for these kids. The correct way is you apply. So I'm going to touch my eye, taking a risk. I have not washed my hand, but anyway. So you can apply the pressure over the sac, lacrimal sac area, like that, and downward massage like that. That's it. Okay. No circle, this thing, right? But it has to be a firm pressure on the lacrimal sac because you have to, that pressure has to go through uh, the cartilage on the part of the nasal bone, and that hydrostatic pressure only, downward hydrostatic pressure will only help to open the valve of Hasner, right? So you can say 10 times in the morning, 10 times during midday, 10 times night, something like that. And you can tell them how to clean with a damp cloth. They can clean. And if the eyelids are having excoriation, you can apply little bit of Vaseline over the eyelids. That's it. Okay. And if the symptoms are not resolving, the natural history is 90% spontaneous resolution over the first year. If it is not resolving, then you can ask them to go to an eye surgeon. So we can do probing surgery. Right? So it has to be managed it has to be managed by a surgery after the first year of life. But until such time, they can try conservative methods. So this is something you would see occasionally. A cyst in a newborn child, or maybe few days or few weeks old baby, the bluish, it's not so bluish in our population. But anyway, something little more dark on the top, a lump there. So it will be very angry looking bread if it is infected. That is called dacryocystitis. But this is a dacryocystocele, right? Congenital dacryocystocele. If it gets infected, you call it dacryocystitis. That needs IV antibiotics, things like that. But here you can manage conservatively. But if it is not resolving over 2 weeks, then the child will require surgery. We don't drain it from outside, we drain it into the nose. So this is the dacryocystitis. It's an emergency. Child will get septic very soon. So you have to give IV antibiotics and if required, problem. So if you are working in, so at LRH, it's not very common because parents won't wait this long until the child gets corneal ulcer. So this is more common in agricultural areas where children go and play in paddy fields. So they get injured by the vegetable matter. They have lots and lots of fungus in this vegetable matter and the rice seeds. So the child will come with, I mean, this is due to neglected corneal epithelial defect, which could have treated early with simple topical antibiotics. So you can see this with your pen torch. This is passed inside the eye, which we call hypopyon. Right? Ophthalmic terminology is a little bit Greek. We don't call it pus, we call it hypopyon. This is the ulcer. This is again part of the hypopyon. And this is blood inside the anterior chamber, which we call hyphema. So you can start a topical antibiotic here and refer to the eye surgeon urgently. Please do not prescribe topical steroids. I have seen a GP who has prescribed topical steroids for his own child to treat corneal ulcer, and the child got blind in that time. So please don't prescribe steroids, topical steroids, without knowing what you are treating for. So this one is a viral ulcer, viral corneal ulcer. So this is the fluorescein staining I told you. Once we put fluorescein dye, it will stain. It will not stain the normal cornea. It will not stain the intact cornea. It will just stain the cornea where the epithelium is denuded. Right? If the epithelium is absent, the fluorescein dye will be taken up by the exposed corneal stroma. So that is what you see as that dendritic pattern in a viral ulcer. So this sort of a child needs proper referral and proper management over many months or many years for successful visual rehabilitation. So this is common in children who travel in trains and bikes. Corneal foreign body. This you can't remove in your practice. You have to refer. Even we struggle. I mean, in an adult, we can remove it in just under the slit lamp. We put a local anesthetic drop. We can ask them to stay still and remove it. But in children, you need GA to remove it. Here again, please, no steroids. You can give a topical ocular antibiotic. This picture is not very clear, but it shows a corneal abrasion. Abrasion is a little bit more sinister thing than a simple corneal epithelial defect. It's usually due to trauma. So this is again fluorescein staining. Right? Here you can see this part. This greenish area is corneal abrasion, which is stained with fluorescein. So this child also needs topical antibiotics and examination of the fundus to exclude other causes of many others things of trauma. So fever and red dye is due to systemic infection. So these days, actually last few months, with viral upper respiratory and lower respiratory tract infections, I have noted so many children have developed conjunctivitis, red dye. But I usually didn't treat it unless they have severe reaction inside the lids. So it usually resolves like any other viral infection without any sequelae. But if they have follicular reaction inside the lid, I treat them with topical steroids just to prevent sequelae of those follicular reactions. So we are off to the last topic. Won't be long, another 5 minutes, maximum 10 minutes. So why squint is important? Squint is the last topic. So here one slide is missing somehow. But anyway, why a squint is important? Because it can be a feature of, a squint can be a feature of sinister ocular pathology or a systemic pathology, right? So just because the child is very small, just because the child is very tiny, you cannot say we can't examine the child, right? You can't just, if the parents complain is a squint, the parents say their child is having a squint, it is your duty to examine properly and refer appropriately, right? To exclude any ocular or systemic cause of the squint. So whether the child is having a squint or not is a different matter. But if the parents complain, you can't take it as lightly. Because I have seen so many cases, so many children, each and every child coming with retinoblastoma to us. If you ask the history, they will say, මාස 6කට කලින් ගෙවල් ළඟ ડોක්ටර් ගියා මුකුත් නැහැ කිව්වා. ඉතින් අපි මුකුත් කරේ නැහැ ඊට පස්සේ. So that is the usual history, right? So please don't do that. If the parents complain is a squint, so what do you have to do? I mean, you are not expected to do a proper eye examination in an infant. You can't do that. Even we struggle to do that. So what you can do is, you can take a brief history, right? You can, ask about the progression. You can ask about when it started, that it was there from the birth, right? So the sort of history we discussed earlier, you can ask. And you can, the minimum examination you can do is the pen torch examination. The pen torch examination we described earlier. Shine the pen torch and see whether the eyes are aligned. If the eyes are aligned, it's kind of reassuring that there's nothing serious. But if the eyes are not aligned, the child needs anyway proper ophthalmology referral. The next thing you can do is to check the red reflex. I showed you how to check the red reflex. You need an ophthalmoscope. So if you can't do those things, please refer. Right? Just don't say Baba podi wedi balanda bෑ. Mechara chuti babalata wapara enawada. Right? So don't say like that. Even very small babies can get squints, which need proper assessment and proper treatment. Right? So don't disregard parents' complaint. So why? So number one is whether this squint is associated with a serious ocular or systemic condition. Number two, whether the child's vision is normal or not. Number three, whether the child is having proper 3D vision or stereopsis or binocular single vision. Right? So those are very, very important. Finally, the cosmetic appearance of the child. So that is the last thing in my priority list. Yeah, one slide is missing that important thing, but anyway, so as I told you earlier, so when I see a child with squint, so I always think about an ocular or systemic cause. So I do a full eye examination and I ask my MOs to do a systemic examination to find out whether this child has a systemic association. And I think about how to rehabilitate the vision or how to maintain the vision. And I think how to preserve or how to improve the binocular vision, the 3D vision. Finally, I think about how to do a cosmetic correction. To do that, of course, you need to do proper examination of this child, because now this squint, you can't just say this is an older child, it's only a cosmetic appearance important, so you can do this even later. I mean, you can't say things like that. Because when you dilate the fundus and have a look, there can be a sinister pathology. Right? So this is only one example. So this is a tumor, right? So you can, I mean, if it is normal squint, rehabilitation with the glasses, there are patching exercises, there are orthoptic exercises, things like that. Finally, the child needs a surgical correction. In certain squints, we do early surgery. In certain squints, we do surgery in appropriate time. So these are few useful antibiotics you can use in your practice. Right? Sorry, I have mentioned a couple of trade names here, but they don't have any other alternatives. So they are the only available preparations. These things you can use for red eye patients in your practice without any. These are dedicated ocular preparations. And for allergic patients, children with red eye and itching, you can prescribe olopatadine. Yeah, epinestine is not available in the market now. Ketotifen is available. Olopatadine is available. Very safe. No, you can't cause any harm with these drugs. Only thing is they can't be ineffective in severe allergy. So in that case, patient you can refer or patient will himself go to a eye surgeon. So yeah, I think that's it for me. Anything else you want to discuss? Anything else you want to know? Any questions? Yes. Yeah, Pingapar is a mythology. No? So she's asking whether it's a slight squint. Is it important to refer? So what you see out from outside may be a slight squint, but underneath it may be something sinister. So any squint you have to refer. But again, to say whether there's a slight squint or not, you have to shine your torch properly and examine.